Good afternoon, everyone. Welcome to our second webinar for this year. If you have logged in, you can actually see the MEPD 2024 Conference and Family Day poster is up. So for those of you who have not registered, please scan the QR code and then it will take you to the registration page. All right. It's going to be for 2 days. So day one would be the conference and then day two would actually be the family day. So it's going to be a quite interesting day out for everyone. So hopefully lots of you will register before the early bird deadline is over. So the early bird deadline is the 11th of April. Okay. So today our webinar is actually, if y'all can already guess from the poster, it's supposed to be about TMJ or TMJ related issues. And today, to deliver our talk, we have Associate Professor Dr. Zuraiza. So Dr. Zuraiza did her undergraduate degree in UM and subsequently obtained her MSc from Queensland and a PhD from King's College London. She's an Associate Professor of Oral Medicine and Oral Pathology in UM, and she is also the Deputy Dean of Student Affairs. She happens to be the President of the Malaysian Association of Oral Pathology and Oral Medicine. She boasts of an impressive CV. When I saw her CV, I actually took about like half an hour just to condense it into the introduction. She has published in numerous journals and has contributed to various research in the field of oral medicine and oral pathology and oral medicine. So MEPD is actually very proud to have her to present in our webinar today. And we know how difficult it was to secure a date with her. So thank you so much, Doctor, for agreeing to do this. And I also know it's not easy to actually deliver a webinar during the fasting month. So over onto you, Dr. Zuraiza. The floor is yours.
Thank you, Dr. Tharani. Well, and thank you for the kind introduction. I'm also would thank MEPD for inviting me to give a talk on. You can hear me well, yeah?
We can hear you.
Okay, all right. So I'll share this screen. You can see the screen, right?
Yes, we can. We can see the screen. Thank you.
Right. Okay. So as mentioned by the chairperson just now, all right. So the title for this webinar today is Unlocking the Lockjaw, right? Okay. Okay. So the outlines of what I'm going to talk today. So we start off with the epidemiology, etiology and factors in TMD, classification, evaluation, examination in diagnosing TMDs, and the treatment options. So I've been looking around for TMD, problems with jaw in pediatric population. There are not many, but I would say, I guess we also start doing in children as well, because we are the, if you have heard DCTMD, that's like a guide for the diagnosis of TMD. So now they has established the examination for children and adolescents as well. Okay, so what is temporomandibular disorders? It's a group of conditions affecting the temporomandibular joint, masticatory muscles, and associated musculoskeletal structures of the head and neck. Okay, in children and adolescents, the characteristic of TMD is same as the adult. So what usually patient comes to you with is pain in TMJ. It could be also in periauricular area and also around the muscles of mastication. Other than that, patient may also complain of, usually also complains of TMJ sounds. And the description usually used by them is either as clicking, popping, rattling sound, or crepitus. And this patient also comes with deviation or restriction in mandibular motion. Okay, in children and adolescents, the epidemiology prevalence it's ranging from 7.3 to 30.4%, and it's higher in female. Most common diagnosis from all these conditions with TMD, the most common found in children and adolescents are myofascial pain and this displacement with reduction. And I come later on this myofascial pain and TMJ disorders. Okay, the causes of TMD. So it could be due to trauma or neurology, and muscular or osteoarthritis mainly in adult or older people, and psychosocial also one of contributing factors in etiology of TMD. And the other thing is mechanical displacement of the articular disc. Important factors that can lead to TMDs are divided into predisposing, initiating, and perpetuating factors. So, and all these factors that will increase risk of TMDs can be systemic, psychological, structural, and genetic factors. Initiating, the cause of onset, usually by trauma, overloading of joint structures such as parafunctional habits, while the perpetuating or the factors which interfere with the healing, the factors are mechanical, muscular stress, and metabolic problems. Right, so taxonomic classification of TMDs. So basically, when we talk about temporomandibular disorders, these are the broad classification. It could be temporomandibular joint articular disorders. It could be the masticatory muscles disorders or headache disorders and the associated structures of the head and neck. Okay, I'm going to touch mainly on the TMJ disorders and masticatory muscles disorders, because these are the most common, as I mentioned earlier, in the epidemiology of TMDs in children and adolescents. So under TMJ disorders itself, there are multiple conditions which in like under classification may be caused by developmental anomalies, example condylar agenesis and condylar hypoplasia. It could be inflammatory disorders such as synovitis, arthralgia, and arthritis. It also under the TMJ disorders there is neoplasm such as chondroma, osteochondromas, and osteoma. Comes next in that list of TMJ disorders, they are maybe caused by metabolic disease such as gout arthritis, synovial disease, and one of the most common TMJ disorders in worldwide population is derangement of condyle disc complex. Under this, you have two subtypes: this displacement with reduction, or and also this displacement without reduction. Okay, I'm going to touch on this derangement of condyle disc complex first. So first we go through this anatomy of the TM joint. As you see here, this is the articular disc, where articular regions, they divided into anterior, intermediate, and posterior, but mainly this is the disc which in this displacement may lead to clicking sound, right? So as long as this is like the normal position where you see that condyle and also mandibular fossa, where it's supposed to be in the middle of it, this articulates, which divide into upper and superior and inferior joint cavities. So I'm going to show you some video, so it will explain better how this article is moving along with mouth opening. Okay, as you see here, that's the articulates, so it's moving along with the condyle during the mouth opening. Okay, so normally it should also, the thinnest part of this articulates should go forward, and it's more of like become the which cover between this condyle and also the articular eminence. Right, go to the next one. Right, sorry about that. That one is the normal. Okay, now we go to the next one.
So,
Okay, so this one is displacement with reduction, in which the articulates is actually anterior displaced. So whenever it's open, it's trying to also adapt to the opening and deflecting, because it's actually the articulates touching the eminent bones and as well as the condyle. Okay. Now we show you the other one without reduction. Right, so I hope that's illustrate well of the TMJ disorders, especially the displacement with reduction and without reduction. Okay, another TMJ disorders which lead to the structural incompatibilities with the articular surfaces itself. So this can lead to either deviation, adherent and adhesion, or subluxation. In deviation, there is like a physiological caused by physiological aging or minor degenerative fluctuations in the either condyle, base and fossa, which cause the deviation and dysfunction, and in which this can be seen when you ask the patient to open and close, and you want to see the pattern of the range of motion. For adherent and adhesion is created by development of fibrous connective tissue or loss of lubrication between the structures, in which clinically there will be restriction in the normal transition with but no pain. Subluxation, which is hypermobility, it's a sudden forward movement of the condyle past the crest of the articular eminence during mouth opening, which is a steep and short post slope. All right, so now we move on to masticatory muscle disorders. Under this, we have myalgia. So myalgia itself, either it's local or is it myofascial pain with spreading, or it could be also myofascial pain with referral. So as mentioned earlier, so myalgia or masticatory muscle disorders are also among the commonly seen in children, pediatric and adolescents. Next is myositis, can also contracture or movement disorders as seen in orofacial dyskinesia or oromandibular dystonia. All right, now I'll move on to evaluation of TMD. So what we would do when patient comes to us with complaint of TMJ pain. So what the first thing usually what best is, as we do with other patients, we take history. And do in TMD, we would have these 3-question TMD, like screening TMDs, or screening of the sign and symptoms. Next to, we have to verify the structure according to the complaint, and we have to verify the structure, which one is actually affected. This is doing so by doing palpation, and we also check for range of movement. Okay, so this 3QTMD, 3 screening questions, which are has been validated, and also in pediatric population, because it's a very simple, straightforward 3 questions. Question 1, asking about like, do you have pain in your temple, face, jaw, or jaw joint once a week or more? Question 2, does it hurt once a week or more when you open your mouth or chew? And question 3, does your jaw lock or become stuck once a week? So basically the question is it's around what patient has been having, whether the problem that the complaint that patient comes with has been experienced by patients a week or more than that. In children, usually we patient is expected, although it's not easy, for 15 days where the patient have the same kind of pain for the last 15 days. In children, usually this also has to be done, also get the verification from the parents as well. Okay, so examination of the TMJ. Okay, as mentioned earlier, so we have to verify the structure where the patient had the pain. Ask the patient to point where the pain is, and then as the examiner, so the clinician will touch and confirm the location. So area that we should check, to be systematic, the pre-auricular area, which include joint, muscle, or both, the joint, locate the joint and ask patient to open the mouth. When we do the examination of the muscle, we ask patient to clench. This is to help us to see the boundary of the muscles. Okay, so all this also being done for similar to confirm process during movement. Palpation. So palpation site, usually the muscle, like mesothelium temporalis, are the most reliable. And also in children, these are the 2 muscles that must be examined, while other muscles like which we do on adults, not necessarily so for the children. Okay, examining palpation. So we usually try to standardize the pressure that we give. So it's 0.5 kg for the TMJ electric poles and 1 kg for muscles and around the TMJ electric pole. And you shouldn't just do like a brief touch when you do the examination of the palpation of the muscles. You have to at least place your finger around 2 seconds and move around and then stay and ramping down. Okay, how many fingers that you use to do when you do the palpation? We recommend 1 finger. But you can also can use 2 fingers for calibration. Whether you want to do bilateral or unilateral, best is to do bilateral because then you can compare both sides, referred one side or at a time. So usually we do bilateral palpation at one time. Okay, so these are the terms that when we do this examination, we would like what type of pain or the pain that when we do the palpation for them to confirm whether it's a familiar pain or referred pain. Familiar pain is pain which is similar or the pain experienced by patient outside the clinical setting. Okay, and when referred pain present outside the boundaries of the test tissue. How does this being evaluated? You have to maintain a steady palpation pressure for 5 seconds before asking patients about pain, spreading, or maybe referral. Spreading meaning is within the boundary of the pain is within the boundary of the muscle structure, while referral should be outside the boundaries of the particular muscles. In jaw movement, what you check or what you try to record is the one opening pattern. So we see either straight, corrected deviation or uncorrected deviation, as you see here, right? So it's either the normal is open straight, corrected deviation. So it's like move to the right and then corrected to the middle again. Uncorrected mean it's just go open up straight to the right and then close. Okay. And we do ask patient to check the pain during opening. We ask the patient to open wide without increasing the current pain. Cut-off measurements for limited opening in children is less than 32 mm, while in adolescent more than 32 mm. Right, lateral extension progressive movement is not necessary in children, but we do in adolescents. Other things that we would want to examine is the TMJ noise. So the clicking, popping, or crepitus during open and close, lateral extension, and protrusive movement. So during all the movement, we need to check whether we can also hear the clicking of just the patient. Both patient and clinician should be able to hear this, right? Not just patient, meaning when we report, it should be, we confirm that patient also have this clicking sound, for example. Okay, so you will usually have to come close to the patient to hear whether there's clicking, and also ask whether that during the clicking opening, if the patients also feel the pain. Okay. Next type of TMJ disorders, the locking. So as the title, open the type of locking actually we have, but it's quite it's very rare in children. So it's the type of locking, the closed jaw lock, open jaw lock, or intermittent locking. Right? Closed jaw lock meaning patient lock in the closed position and unable to open. Open jaw lock, patient is the mandible is locked in open position and unable to close. Intermittent locking, patients able to maneuver and get back to the position it should be in, and mandible can come back to the normal position. Okay, next, this is the diagnostic position tree that we use here in UM. This one has been like recommended to be used for, because before this, it was meant for research. The name old name is Research Diagnostic Criteria, RDC-TMD. But it has been like going through all the research and many research. And also I think around the world, they have this committee and they finally come up to this one where they remove the research. It's also meant to be used in the clinical setting. All right, hence here the CTMD. So as you see here, pain-related TMD and headaches. This is like I say, first you start with history and then examination diagnosis, and you have this decision tree to refer to when you come up with a diagnosis. All right. Yeah, I think I will touch on a few from this. The myalgia, arthralgia, headache attributed with MG and joint disorder. Okay, so what is myalgia? Myalgia is a familiar pain in masticatory muscle with palpation or maximum opening, but the pain is just at the local area of the where you palpate. Myofascial pain, familiar pain with muscle palpation. Pain is spread but not referred. Spread within the boundaries of the muscle itself. Myofascial pain with referral, familiar pain with muscle palpation, but also at the same time referred when you do the palpation to the other structures. Arthralgia, so during examination, familiar pain with TMJ palpation or jaw movement. So these are diagnoses for TMJ pain. Headache attributed to TMD, headache affected by jaw movement and function. And in this characterized by familiar pain from temporalis area from either palpation of temporalis or when patients open and close range of jaw movement. Under joint disorders, I think these are the type of joint disorders which I have covered earlier, just that this one is characterized after during the clinical examination by when this displacement with reduction, you will hear clicking. This displacement wave reduction with intermittent locking. Clicking during examination, intermittent locking, when you ask the patient to open wide, you can feel like it's taking time for patient to maneuver and come back to the normal position. Degenerative joint disease, you will hear crepitus during examination. This displacement reduction with limited mouth opening. At the time when patient comes to you with a current jaw lock. This displacement without reduction and without limited mouth opening, prior jaw lock with limited mouth opening, subluxation, TMJ locking in open position, which require maneuver to get the mandible back to the normal position. Next, treatment options. Main aim in treating patients with TMD is to alleviate the main signs and symptoms. And usually we do conservative treatment. Number one, self-management strategies, occlusal spleen, physiotherapy, and medication. Surgical interventions such as arthrocentesis, which based on articular lavage with or without injection of pharmaceutical, and also arthroscopy. Usually this is like last option that you want to even discuss with the patient, but there is no guarantee after the surgical intervention that the condition will, the TMJ disorders won't recur. So I'm not like this is not my preference. So usually we do conservative treatment for, and especially for pediatric population, I think conservative treatment is like a way to go when we discuss about the treatment for these TMDs. Okay, what under self-management strategies, what we advise patient, we ask patient to having this soft diet, okay, and they can also do hot pack compression, voluntary disengagement of teeth, and modify non-perpetuating factors such as we can advise patient to chew on both sides to make it balanced rather than just one side of the mouth, and avoid sleeping on the affected sides. One of it, and also we soft diet, patients should be avoiding all the chewy foods. Okay, so in pediatric population, this self-management strategy should also be discussed with the parents to educating both the parents as well as the patients. It's important thing for a successful management treatment. Okay, next, medication. Okay, for medication used in TMJ pain and TMJ degenerative joint disorders, one of the most common ibuprofen. Here I took from a paper which they have list of medication can be used for the infant and children and also adolescents. All right, naproxen and then also diclofenac. Right. For Brufen is one of the mostly, I mean, I would prescribe, okay, because although it's not necessarily help, it will help a bit, but this is one of the Brufen will be here in where I work. I usually prescribe. Okay, for infants, children, so 6 months to 12-year-old, 5 to 10 milligram per kg orally every 6 to 8 hours needed. For adolescents over 12 years of age, 200 to 400 milligram orally every 4 to 6 hours as needed. And the maximum for Brufen is 1,200 milligram per day. While others, okay, let's go for the next one. Meloxicam, celecoxib, and acetaminophen can also be given. Okay, I don't think I should read here. All right. Okay, we go for the next one. List of medications in masticatory muscle pain disorders or chronic pain disorders. Number 1 is amitriptyline but usually we only prescribe this for adolescents. 1 milligram per kilogram per day orally in 3 divided doses, increase after 3 days to 1.5 milligram per kilogram per day. Here, this, like I said earlier, so this list actually I got from a paper, but where I work, for medication for muscular muscle disorders, I give amitriptyline or other muscle relaxant like cyclobenzaprine. And again, for this medication, it's a strong medication. We usually give more to the adults rather for the infants. Cyclobenzaprine, for example, only for adolescent the age of 15 years and above, which given 5 milligram orally 3 times a day. Okay, can be increased to 10 milligram orally 3 times a day based on response, but it shouldn't be given longer than 2 to 3 weeks. Okay, so these are the example medication which I'm not actually familiar with, but these are other options for masticatory muscles pain disorders. Right, so these are the lists where I usually give in my clinic, although mainly I give for teenage like 15, 16, 15 to 9 to 18 years old when they come to us with PMDs, but basically mainly this kind of patient, they get all these TMDs, painful TMJ when they are about to sit for exams. Okay, so when it's the SPM season, I see a few of them. Okay, so in our clinic, so what we usually give non-steroidal anti-inflammatory drug and NSAIDs. Corticoids, although it's listed here, but I will save it later. All right, so that one main medication is the NSAIDs, analgesics, and muscle relaxants. While tricyclic gabapentin lidocaine I give for adult patients, but not for the young teenage patients. Right. Okay. So, and muscle relaxants that we use in our clinic are Norgesic, which contain of nadrine citrate, the muscle relaxant, as well as some analgesic in the paracetamol. Okay, and we give up to 2 taps TDS. Right. Okay. There's one option of the methyl salicylic cream. It's like just cream to be apply over the muscle. It's kind of like what we call here minyak panas. So somehow it does help. It has some kind of like a warm feeling. So this somehow works for maybe few patients. Okay, next, in management, other than soft diet and all those things, some of the patients we also advise to do therapeutic exercise. So in this exercise, so we ask the patient to open and close, but not to force to open the mouth too big. I mean, which make the pain worse. Okay, so what does this do? Exercise focus on improving motor control and endurance of the masticatory muscle, which is effective in alleviating the symptoms of patients with TMD. But exercise does not produce greater pain relief than other interventions such as TENS, occlusal spleen, and patient education and acupuncture. I'll come back to the TENS. Okay, so heterogeneous in stretching, linguomasticatory relaxation, and coordination exercise, among others. So it's not from one patient to the other the way that we advise patient. It's depending on how the patient can tolerate. I mean, usually what we do here, we ask the patient to open at certain distance a day, and then can increase the opening to after like a few days later. Right, next, another option for management and electrotherapy. However, current evidence does not support the use of electrotherapy for pain relief in patients with TMD. So example of this are pulse radiofrequency energy, transcutaneous electrical nerve stimulation TENS, and low-level laser therapy, which is actually heat-related therapy. However, it show no better result than the respective placebos in the treatment of TMD. And usually these are the type of treatment where we refer the patients to have all this done at the physiotherapy center. Okay, so the option of management therapy is occlusal spleen therapy. Okay, there are different types of occlusal appliances have been used a long time ago to treat TMD. But until now, there is considerable debate about the design of occlusal appliances and how they should be used. There are a few types of appliances, and I'm not the expert of that, but we do work together with the prosthodontists because they would be like the one who knows better which type of appliance suitable for patients. Okay, mechanism of action of spleen, what we try to achieve when we do spleen therapy. We try to reduce the TMJ related pain, increase the range of motion, and improve joint function. So the mechanism of action is through the occlusal disengagement, restoring vertical dimension of occlusion, at the same time to relax the muscle and unloading the joint, and also repositioning the TMJ. Okay, so there's one study saying that in patients who use this occlusal spleen, there's a plasma level of calcitonin gene-related peptide increment, which this peptide is playing essential role in stretching and relaxing muscle, neurogenic vasodilation, and maintaining the functional integrity of peripheral tissues. So it's indirectly the spleen can help with muscle to relax. Like one of the most popular spleen that we prescribe for patient is the flat plane stabilization appliance, Michigan spleen. The purpose of the spleen to provide joint stabilization, protect the teeth, redistribute the occlusal forces relax the elevator muscles and decrease bruxism. Additionally, indirectly, it's also increased patients' cognitive awareness of oral parafunctional habits, because by having the spleen inside, they have to limit certain movement, thus altering proprioceptive input and central motor areas implicated in masticatory function. Okay, so because it's not much being done in children, or research done in children. This is one example, which quite old one, is 2015. Treating temporomandibular deficit in adolescents, where they compare the relaxation training and occlusal appliance therapy. Relaxation training, basically the self-management therapies in which a patient, cognitive behavioral therapy, patient has to try to relax, understand the problem, and relax the muscle by doing some exercise or meditation, or also pace breathing. Okay, in this study, they found that use of standardized clinical treatment with OA is more effective than self-evaluation of treatment improvement, then relaxation training. Okay, otherwise, all these meta-analysis and all are usually done in adult. Okay, somehow I would like to highlight where the evidence in that meta-analysis support the use of spleen for TMD. Okay, here is 45 minutes because it was mainly the adults studies. Okay, less maximum mouth opening less than 45 millimeters showed a statistically significant change with spleen therapies. However, if the mouth opening greater than 45 millimeters did not show any significant change. So basically, spleen help with problems with who has a very severe limited mouth opening and significant or severe pain, but it does not treat the TMJ clicking. Okay, so if like the patient expecting with spleen, it will also clear with the TMJ noise problem, that would not be achieved. It's not achievable. Right, so this one I just want to show that neurotherapeutic mechanism of spleen therapy, how the spleen therapy relates to the brain. Okay, in this study, they showed that spleen therapy can impact the neural function of brain regions in TMD patients, accompanied by improved clinical symptoms, suggesting a central mechanism underlying the therapeutic effects of spleen therapy. Okay. So this study, like based on the MRT, I just want to show you that there are studies comparing and try to prove, show evidence of the advantage of using spleen. Okay, I think that's all. These are the references that I use. And thank you. And I would like to also thank you, Dr. Nur Fauzani, who helped me with the preparation of the presentation. Okay.
Thank you so much, Dr. Zuraiza, for the very enlightening talk. We have a question here in the chat box, actually. It's by Dr. Aimi. What she says is that, hi, doctor, I am having patients wearing conventional fixed appliances and complaining of pain at the TMJ area when using the elastics, especially in those class 2 cases. Patient experiences pain upon opening the mouth and also the TMJ area. What's your opinion, doctor?
Okay, so what I would want to know, whether the pain, like you say, it's just when they put the elastic band, right? It's not like a continuous all the time. So we have to differentiate whether the pain is, although it's like in that area there, so probably it could be related to some, when the patient have this pain jaw, they also try to adjust the open and close, and also when they're eating. So the adjusting movement may then lead to this the muscle, this not muscle joints, it's like muscle pain, because when doing adjustment, you're not actually open and close at the normal position. Anyway, but this, I think, if it can be treated by just prescribing any type of NSAIDs or maybe some, but I think in adults and in children, I usually try not to do that. I mean, prescribe any medication, we start with all these self-management therapies first. So like heat compress, heat therapy, and things that you can do at home rather than going for taking any medication. I hope that helps, but otherwise we also have to, if like self-management does not help, then next I will prescribe medication. Would that answer?
Does that answer your question, Dr. Aimee? I have another question actually, and this one was like texted to me. They want to know, say if a patient they're complaining of TMJ pain or dysfunction, what type of imaging is can we help to take? What helps actually? I mean, some people take TMJ open and close or reverse Townes.
Yeah.
Does imaging help to see, and what kind of imaging would you recommend us to take?
Okay, right. So actually imaging is not like my routine part of investigation when I do examination of TMJ. Why? Because most of the TMJ problems or TMJ disorders, especially, it's linked to the articular eminence, the way it's not articular eminence, the articular disc, okay? So the dysfunction of the articular disc, which means if you're taking just the conventional imaging, you won't be able to see soft tissue. So you will only see the bone. Unless I suspect any bone disorders, bone-related disorders, like I want to see the shape of the condyle, whether it has some deformities or anything like that, then I will do imaging, which usually these days, many patient comes with DPT. I can just look at that shape of the condyle and see if there is any bone disorders, bone diseases there. But I wouldn't ask for that. I think old days, yeah, they used to send a patient to get all this open and close. It's more like to look at whether when they open, how far the condyle goes, as we see the video there. So that's the only thing that you're able to see. But like I say, it's the engine is also related to the articular disc. You won't be able to see how that articular disc blocking or hindering the movement of the open and close of the condyle itself. So, but these days, as I say, I don't have to send for imaging unless I suspect any, just want to check any bone deformities or bone disorders.
Thank you, Doctor. That's quite like enlightening for me as well, because I mean, yes, I think about like, I would say 6 or 7 years ago, people always advise us to take, reverse Townes, TMJ open and close. And sometimes, yes, we can view something, but most of the times it's quite blurry. We're not really very sure where to look for and whether we can see, unless if there's like some reduction or something that we can see visually, there's some bony involvement. Otherwise, it's very difficult to see.
Yeah, you're only able to see how far the condyle goes in front of
yeah.
Correct. Of that eminence.
Okay, there's another question here. They wanted to know, say, does orthodontic treatment in a patient with TMJ issues, will it worsen the TMJ issue? Do you think it was? Is it supposed to be part of the, actually this I think is asked by an orthodontist. Should they include it as part of their informed consent? If you have a TMJ issue, it might worsen.
Okay. Right. Okay. I think over the years, with colleagues and all, I've heard about this where orthodontic, if it's not worsened, it can also be like the cost, although like not a direct cost, but after this patients having or had orthodontic treatment done, and they start having this TMJ problem. But in literature, there's no like a strong association. They don't that say orthodontic treatment leads to TMJ problems. If like clinically in the real situation where I have patients, if like an orthodontist who want to do and patient requests for orthodontic treatment, what I guess this is more of like my opinion. probably work together with oral medicine or any specialist, just like, before starting the orthodontic treatment, being assessed by oral med specialist, just to see, to get the understanding, patient understand what is he or she having, and then start the treatment. But at the same time, if like patient start having all this problem and can come to the oral med specialist, and we can I guess treat by symptomatically with the problem itself. Otherwise, I think, yeah, because there's no evidence saying the strong association between TMD and orthodontic treatment.
Right. I hope that helps answer the question from one of my friends here. Another question is, okay, so TMJ, PDS, and atypical facial pain, is it correlating with each other? How would you like differentiate when someone is having atypical facial pain, or is it TMJ related issues? Is there like a difference, or are they all actually pretty much the same thing?
Okay, right. Okay, one thing, TMJ-PDS. I think all term that we use these days, we use TMJs, but under TMJs we have TMJ disorders or myasthenic muscle disorders. So to differentiate between these two, the TMJ problems versus the atypical facial pain, right? So to confirm whether the patient has this TMJ problem, so first thing, I think we should do all this examination according to the recommended systematic examination, like the one that I touched a few today. So some of it is actually following the DCTMD systematic but comprehensive long examination, which if we do for children and also adolescent, I think not too bad, because for adolescent now they recommend to also use the same comprehensive long list, extensive list of what examination should be done. But for children, they have shortened it, and there are only a few things that can be skipped. Like I mentioned just now, you don't have to do the lateral protrusion examination. Okay, so the difference would be for TMJ. If you follow that systematic examination of recording the pain, type of pain, where and use that clinical decisions that I showed, so that would then help you of diagnosing TMJ. Otherwise, because one of the three will also indicate where you don't see all this, it actually another. It's not TMJ. It's not TMDs. It's other condition. However, however,
it's like a diagnosis of like exclusion then. So we
Yes.
slowly go through the list and then, okay, that makes sense.
But I think atypical facial pain would have I think different characteristics as well. So yeah.
Thank you, Doctor. There's another thing here. There's a question here. So, Doctor, I've been on call before, and a patient has had a locked jaw at the closed position. And this is an adult patient, apparently. So, what can I do to relieve that thing? Can it become unstuck? Is there any like conservative way where, how do you make it become unstuck is the question. Like, is there anything that we can put on the jaw area, any massages, anything that we can do to make it become unstuck?
I think maneuver is one main how you manage or how you actually deal with it. Okay. For me, if like any locking jaw, I would try, especially in adult patient, they actually have been having that a few times, right? They would also know, I would ask them, have you had this before? And then what did you do before when you have that? But at the same time, for us, we help with maneuvering by pressing down just to get, if it's locked, meaning it's either stuck between the condyle and the eminence. So you try to get it clear and get it down away, then it can go back to the normal position. But somehow I say, maybe, I think I saw one patient who doing that by massaging his own masseter around there, and he got it back, I think, because he said he's been doing it that way. So I didn't have to help, like, press down and press it back to the normal position.
Disengage and we put it back. Okay. in terms of disengaging the teeth, like other than occlusal splints, is there anything else that you would recommend we use? Like, is there any like what other ways can we disengage? Is there like, because there's some studies that where they say you can use the tip of the tongue against the palate in a rest position so that your teeth become disengaged.
Yeah.
So you don't have to actually use the occlusal splint. Is that helpful? Can we like train our patients to do that? So basically now, what they're saying is that in rest position, there's always supposed to be about a 2 mm space, even when
Yeah.
our mouth is closed. But a lot
Yes.
of people nowadays are clenching, and that's contributing to that. So do you think that would help, that tip of tongue to the palate kind of
Yeah.
exercise?
Okay. In the therapeutic exercise where I mentioned just today, that's part of it is open and close, and also by asking the patient to put the tip of the tongue. So it's more of like to limit the opening. That's one of it. So by we advise them doing that for open and close. We can also advise them just like to make sure that they don't clench, right? Upper and lower teeth, upper with against the lower teeth. That would be one of the advice I give to patients as well. It's just that again, so that's the importance of educating patient and parents, because it's it's hard to break the habit. Hence the spleen coming is more of like it's there. So, and then by having this teeth always like being controlled by the spleen, so they would then change the parafunctional habits by having spleen there. But yeah, we try with that first, educating, and then advise and explain for them to understand what's the importance of we asking them to do that. And then if it doesn't work, then spleens comes in.
That's about what questions that I actually have. There's no other questions in the chat box. So I guess let me check again my messages, because sometimes people tend to just text me. Doctor, could you put up the the algorithm for treatment? You had that nice tape, that
Yeah.
chart where is it from? Is there any way that we can download that?
That's
Because I think
that
that's
one
quite
is if you Google DCTMD.
DCTMD, okay.
Yeah, disease slash TMD. So that
Mhm.
would be the then there will bring you to this network where it has all this guideline on examination and also decision tree. So examination is the forms that I mentioned, the comprehensive list of examination you should do.
Mhm.
It's also in that booklet.
Okay.
But
Right.
this book is mainly for the adults. Again, because this time is like a consortium. They have this before this the name was Research Diagnostic Criteria RDC/TMD. But because we have all different criteria from one center to the other, so it's hard to get a very strong evidence and conclusion when they do research, and when we try to do research. So now they have through all the meetings and everything, so they make it remove the research, because basically what they do this after like many numerous work. So they also recommend this can also be used in the clinical setting. However, it is quite extensive. We do this in our clinic. But it's the diagnostic tree is very good, like a very good like guide for you to be able to help you with the diagnosis of TMDs. I'm not sure whether they're going to come up with another one for children, because we don't have other papers that working on whether they want to make some changes or any changes with all these criteria, and they do when they diagnose in adults, but in children they have other criteria as well. But in adolescent, I think they use the same. It's just that the cut-off measurement is less than the adults.
Okay, thank you so much, Doctor. So to summarize today's valuable input from you, it will be like we have to take proper history from the patients. So history is everything. So we'll know sort of what is the source, where is the source. And then I quite like the one where you say we have to like properly do our examination as well. So it's not just touch and go. Very often, sometimes you might see the younger junior doctors just touching and say, oh, there's no pain, and then they just let it go. So there's actually, you have to put in 0.5 kg and an even even amount of pressure in order to elicit a proper response. And then in terms of relief, there's always the symptomatic relief first before we go into before we go into the analgesics. And then the very end of the spectrum is, of course, the surgical approach. And then the take-home message that what I got from today is that there's no like one size fit all. All the advice has to be tailor-made to each patient and whatever that they are facing at the moment. So it's not like there's a formula for this, but to treat or manage TMJ issues.
Yes.
It's more like tailor-made kind of advice. So I think for me, it's one of the very enlightening talks, because always TMJ, sometimes we skip straight and we go straight, let's provide a splint for the patient. But actually, if we go through the history, we might actually come up with a different sort of way to manage the case. So I find today's session very helpful. So thank you so much for spending an hour of your precious lunch time to give us this talk. If no one has any other questions, can all someone wants you to help share the screen again for the flowchart.
Oh, okay. Right. Yeah.
So thank you again, Doctor, for today.
Welcome.
For those of you who have not filled the attendance, please do so. The link is provided in the chat box. I will repost the link again one more time. Here we go. Right, so this is the flowchart. Okay.
Yeah, just Google DCTMD, DC/TMD.
Okay,
Yeah,
great.
then we'll get, it actually has another part of diagnostic tree that is meant for this one is for the pain-related TMD. There's one intra-articular joint disorders where the subluxation, the locks and all. So
all right.
yeah,
Thank you.
It's a good help.
Thank you. Thank you so much, Dr. Zuraiza. Thank you for your time. Okay, I will be closing up the channel soon. For those of you who missed the talk today, it's also available on YouTube. Okay, and that's it. Thank you so much, Doctor, and thank you everyone for listening.
Yeah, thank you. Thanks to you and thanks everyone as well.